So good day again. Welcome to this webinar from HDHL, Rethinking Type 2 Diabetes, Effective Prevention Strategies and Overcoming Barriers to Implementation. My name is Norm Rosenblum. I'm the Scientific Director of the Canadian Institutes of Health Research Institute for Nutrition, Metabolism, and Diabetes, and have the pleasure of being the moderator for today's webinar. We're going to have three excellent speakers speak to the issue at hand, but we'll begin by having an introduction to HDHL from Eileen Gibney, who's the chair of HDHL. Over to you, Eileen.
Thank you. Can everybody hear me now? Yeah, great. So just briefly before we get started on our interesting topics for discussion today, I just wanted to remind everybody about HDHL and what it is, and I suppose why these activities like today are very important to us. So HDHL brings together about 14 countries that align their research programming and fund research to prevent or minimize diet-related chronic diseases, and really want to bridge that link between food and health. It's a kind of a public partnership and looks at cooperation across member states, where we focus on the societal challenges that relate to food, nutrition and health, really understanding how much food can have an impact on food, nutrition and lifestyle can have an impact on health and overall quality. We are mainly European countries, but also include Canada and Brazil, and welcoming our Canadian colleagues here today, and thanks for their work with this webinar. And our members comprise of ministries, funding agencies, research institutes, and institutes from the food sector, etc., to tackle these societal challenges together. We're involved in several European initiatives, which really work across a number of pillars. So if I could have the next slide, please. And what we really aim to do with our overall activities are to create kind of, I suppose, a forum for a think tank, where all these, our network, our members get together to discuss and to talk and to really think about providing expert advice to guide the discussions at a European and a global level to anticipate the challenges that guide the future of food, nutrition and health. So it's a really important network where we can bring our members together to see what are those individual challenges within each member, but also then what are those global challenges and what are the strategies that we should have to address those. We want to then strengthen the collaboration and mobilize those synergies into practice and to really have an impact on policy. So liaising then with the wider stakeholder groups, so whether it's the European Commission here or FAO or other organizations, to really sort of try to sort of influence policy we can at that global level. And we're also very keen on funding transdisciplinary and interdisciplinary research to create that knowledge to address those societal challenges. And again, it's always at the intersection of food, nutrition and health, recognizing that link between those. Next slide, please. So we are involved in a number of activities. One of the core activities at the moment is the involvement in sort of leading food for health. And this is a coordination and support act funded by the European Commission, awarded to HDHL and Food for Health. So it's about 2.4 million. And it's really taking that to align the national research and innovation programs to avoid the duplication. So that's one of the key things, that bringing these 14 different countries and wider countries together is to be able to sort of say, well, what's everybody doing over there? How can we join to make sure that our work is synergistic, building on each other, and avoid that duplication that may often happen in some things. So it'll build on the efforts of the past. So those could be the previous coordinated support actions of microbiome, Fit for Food, Clever Food and Food Paths, all of which you can find further information on various different websites. Next slide, please. So our overall vision then is to provide or to support, moving forward a healthy diet, a healthy life, and a healthy planet for all. And it's, as I said, to address those societal challenges. And that leads me nicely then to the topic today, because one of those societal challenges that we know we are addressing is the rising risk of obesity, and then a lot of the morbidities that come with that, particularly type 2 diabetes, and the need for all members and all countries to really rapidly address this. So our speakers today are going to take different looks at these, and I hope for a really interesting discussion from everybody at the end, and delighted that HDHL is here supporting these webinars. So I'm going to hand back to Norman now.
Thank you, Professor Givney. That's great. I must say it's really a pleasure for us in Canada at the Canadian Institutes of Health Research to collaborate with all our partners in the HDHL, which we've been doing for some time. So I'm just going to present some context now before we have our speakers present to us in turn. So let's just remind ourselves of data that we're probably quite familiar with, but are startling nonetheless. And these are data from the International Diabetes Federation. Over 90% of people with diabetes have type 2 diabetes, so type 2 diabetes is clearly the highly prevalent type of diabetes. And if we look at projected prevalence starting in 2024 and then projecting forward to 2050, one can see a remarkable projected increase in the prevalence of type 2 diabetes generally in the world. So one can see this in the blue, but go continent by continent. Africa, 142% increase. Europe, a more modest increase, but already highly prevalent. A major increases projected for the Middle East, Southeast Asia, South and Central America, and also a 20+% increase projected for North America and Caribbean. So one, we have a highly prevalent condition, and secondly, it's projected to increase remarkably as time moves forward. Next slide, please. The cost attendant to this disease is extraordinary, actually, and it begins at somewhere in the neighborhood of presently starting projected from 2006, 200 billion US dollars, projected to a trillion, over a trillion by 2050. That's dollars, but we can easily understand the cost to individuals, families, communities, and societies is quite incredible. Next slide. What we know is that there is evidence from a variety of sources that type 2 diabetes is preventable. And here we're just showing one example from the group of John Piper, published in Nutrients. And I think there's certainly adequate evidence that using a variety of different tools, lifestyle changes, nutritional changes, that to achieve weight reduction, which is a central part of this type of strategy, that prevention can be successful. However, all said, notwithstanding our knowledge in this direction, the data show that we're going in the wrong direction. Next slide. So the question for today, if we know that type 2 diabetes prevention works, why do prevalence rates and the burden associated with type 2 diabetes continue to increase? That is the vexing question on the mind of not only all health professionals, but all individuals who are involved in health policy and implementation across any country. Certainly I've been in contact with it in my position as the scientific director. So next slide, please. So let me introduce, we'll have three speakers. They'll speak for approximately 15 minutes each. And then we'll have a period of questions and comments. And you, the attendees, can register your questions and comments in the chat, and we'll try to keep track of that. And it'll be interesting to have those directed to the specific individuals in question, but also to hear our three speakers on a panel towards the end of this session, reacting to each other's, to all the questions and also each other's comments. So it's really a great pleasure to start with Dr. Mary Jung, who's a professor at the University of British Columbia, the Okanagan campus, that's in Canada on our western coast. And Mary is coming to us, it's very early in the morning, in the 3 hours earlier than where I am in Toronto, Canada. So thank you, Mary. And you look like it's 12 noon. You're so awake and spry at this early hour. So we look forward to your talk. Thank you.
Thank you very much, Dr. Rosenblum, for the introduction. I'm very excited to be here. So, all right, I'll just start sharing here. Thumbs up that you can see this okay, Nora? Yes, okay, great. Well, I'd like to also take this time to thank Healthy Diet, Healthy Lives for the opportunity to share some of the research that I'm very passionate that we get to do here in Canada on the topic of diabetes prevention. So begin by respectfully acknowledging the unceded and unsurrendered territory of the Syilx Okanagan Nation, of which I currently live and conduct my research. And this is a picture of our beautiful Okanagan Lake right in my backyard. So in addition to the IDF stats that were just shown, we know that the rates of prediabetes are even higher than clinically diagnosed type 2 diabetes, with one in 5 Canadians having prediabetes. More than 80% of those individuals in Canada don't know they have prediabetes. And this is concerning given that without intervention, diet and physical activity approaches, approximately 70% are estimated to progress to type 2 diabetes within their lifetime. And so this is really the impetus for the development of an evidence-based intervention that my program and participant partners decided to call Small Steps for Big Changes. So essentially, this is a counseling program that we use to empower individuals living with prediabetes to make lasting diet and exercise changes. And we do this through a very purposeful, brief, evidence-based counseling to ensure the sustainability and the cost effectiveness of the program in communities. And so very briefly, Small Steps for Big Changes entails 6 one-hour sessions that are conducted one-on-one with a non-professional or lay person that lives in community. What that individual does is provide motivational interviewing informed counseling for approximately 40 minutes of each hour, followed by approximately 20 to 30 minutes of supervised exercise. And then we do engage in follow-up sessions, one to collect data to assess how successful or unsuccessful the program has been, but also we do check-ins to assess how the participants and how the individuals in community are doing. So people often ask, what is the secret to the content of Small Steps for Big Changes? How does it work? So briefly, within our motivational interviewing counseling style, we're very focused on, like I said, empowering the client or the person in front of us. So that means we highlight autonomy, supportive communication styles. We do a lot of listening and a lot of understanding where the patient is ready to begin their journey. Textbook-wise, our intervention components are listed here in the bottom green. Again, we focus on behavior change techniques that are specifically potent for eliciting changes and maintaining changes to diet and exercise in this population. But ultimately, I would say in one sentence, we don't prescribe, we converse. So this is our big premise that assists us in empowering people with prediabetes. Another secret component that's not so secret anymore is our big focus on training non-professionals. This reduces costs significantly from other worldly diabetes prevention programs that require licensed healthcare practitioners. So we do this through an asynchronous modules. There are 7 modules, and I'm just showing you briefly here module 1, which we're particularly proud of. We've tested separately this module, which is on training individuals how to provide culturally safe and inclusive care when engaging in conversations. Of course, when we're looking at aiming to enhance the public's aspects of providing diabetes prevention care, we know that those most at risk are those individuals who are facing inequitable barriers to healthcare. So after individuals working in fitness facilities take our training and pass our training, they are then able to deliver small steps for big changes. I'm going to hint at one of the reasons that I think that to the questions that Dr. Rosenblum put up there. I think one of the challenges with past programs is the lack of focus on equity. And so we do this in Small Steps for Big Changes in a number of ways. I won't have time to detail out right now, but essentially we are very focused on food insecurity, individuals who are new to Canada, as well as prioritizing equity owed individuals, as well as places, so urban and rural areas where there is a paucity of diabetes prevention programs. In the interest of time, I'm just going to focus on sharing a little bit of data with you from one of the phases of our research. And this is, we were doing some hybrid effectiveness components. So briefly, we started with about 400 people enrolling in Small Steps for Big Changes. And then coming through our 4-week program, so those 6 sessions are delivered over a number of, or 1 month. And then we followed up at 1 month, 6 months, and 12 months. Now, unfortunately, this particular consort, we experienced a COVID-19 pandemic. So we had an undesirable number of failures to or loss to follow-up in this data set. But nonetheless, I think it's quite interesting to see what happened over that time frame. So I'll orient you to these graphs here. In panel A, you see changes in HbA1c, panel B, waist circumference, panel C, weight, and in panel D, the distance walked. And this is using the 6-minute walk test, which is a validated test for assessing cardiorespiratory fitness. The gray vertical bars in each one is the amount of time, or is the actual time of delivery of Small Steps for Big Changes, which I said before occurs over 4 weeks. So it's a 1-month period. And essentially what you're seeing in this submitted unpublished yet data is that there are significant changes in the expected directions, the desired directions. And what we're most proud of is again, that after a 4-week intervention, we do no more intervening, but when we followed up again at the 12-month time point, these changes were sustained. You can see here physical activity. So this is minutes of both moderate and vigorous physical activity combined. And we are pleasantly surprised to see that, again, 12 months after completing our very brief intervention, there is still significant improvements in physical activity. This one is a bit more colorful to present, but I thought I'd share in the interest of HDHL. And so essentially what you're looking at is the changes in proportions of consumption of from A to D fruits, vegetables, sweets, breads, and white rice and pasta. And so what we aim to improve upon in the program is an increase in consumption of fibrous vegetables above ground. And we aim to reduce the consumption of added sugars through sweets and sugar beverages. And we focus on reducing refined carbohydrates, which is a bit more nuanced than just simply bread and white rice and pasta, of course. But essentially what we did find with our program is significance in the targeted intervention components. We still measured fruit just because it's part of the validated tool, but we didn't see a change in fruit as expected because we didn't target it. Perhaps most exciting, though, is that 12 months after completing our brief intervention, we see that 41% no longer had prediabetes. According to IDF and American Diabetes Association's criteria of prediabetes of 5.7 to 6.4%. And then we had a further 16% sitting right at the 5.7% value, so just on the cusp of no longer having prediabetes 1 year after completing small steps for big changes. So where we're at right now is with funding from CIHR and the National Health and Medical Research Council of Australia and the Public Health Agency of Canada, is examining the scale up of this across Canada as well as Australia. And so our project aim here is evaluating the implementation and effectiveness of small steps for big changes in diverse urban communities. And we're using a hybrid type 2 effectiveness implementation trial here. And so what this means is that we do have dual primary aims. We're focusing both on the clinical effectiveness as well as on implementation to assess rapid translation of our findings into the community. So the plan for this project, and I'll share where we're at right now, is initially expand to 11 urban sites with high diversity populations, and then expand to 33 additional sites across Canada, as well as test in 5 sites in Australia. In each of our 11 initial sites, we're recruiting 400 participants. And then in each of our 33 expansion sites, we're recruiting an additional 100. And to do this, we require training a lot of, like I said, non-professionals in these communities, which speaks to our aims of sustainability. Our numbers in the state of Queensland, Australia, are smaller with their smaller team and just a focus on the first phase of assessing implementation in a different continent. So I won't go over all of our implementation questions, but just in summary, we want to know, who does this reach? How can we reach those most at risk? Can it be implemented at broad scale? How can we do this in an equitable manner? And what factors are associated with successful implementation? For our effectiveness research questions, again, won't belabor them here, but we want to know essentially, does it continue to work as we've shown in the past? Does it work at the organization level? Is it cost effective? And at the public health level, is it cost effective? We're doing an additional sub-study that I thought you might be interested in knowing about. This will include a smaller subsample, of course, of our larger sample of 1,285 individuals. And we're going to follow these individuals for 24 months to assess changes in A1C, and we're oversampling specifically for equity owed groups. So right now in our current path, we have expanded into or implemented the program into 13 cities across Canada thus far, with registrations at about 400 participants. And in our sub-study, we've enrolled 70 participants of those 400. And we're being successful in targeting those who we strive to sample from. Our ultimate aim is on sustainability. So we need to assess, does this continue to work? Is it effective? But also, if we are going to make an impact at the public health level, we need to develop and sustain strong partnerships such that our community partners have the skills and will be willing to continue to deliver small steps for big changes long after funding has ceased. And so with that, I will end there and thank you for your time and are open to answering any questions.
Thanks, Mary. Wonderful talk. So I think we'll hold you in reserve if we could. Please, I know you'll be attentive to our other two speakers, and then we'll look forward to our discussion period. And could I have my slides back for a moment? And it's a great pleasure to introduce Dr. Jaana Lindstrom, who's the research director of the Finnish Institute for Health and Welfare, who will speak with us next. Dr. Lindstrom, please, and thank you.
Thank you. So could you show me my slides, please? Did you receive them?
There we go. Good sign.
Right. So I'm going to talk around the same topics that we heard in Mary's presentation previously. Maybe taking a step backwards a little bit, looking at our successes and maybe the challenges over the years. And as we were asked this question about, as we know that in clinical trials prevention works, why do prevalence rates and the burden continue to increase? So that I took that as the topic and title of my presentation. So could you give me my next slide, please? So I also wanted to start by making presenting a little bit about where I come from. So greetings from the happiest country in the world. We just a few weeks ago, we were selected again, the happiest. And probably we are not the happy kind of people, but we do have some kind of trust in our institutions, equality, and maybe also the healthcare system. So how does that relate then to our diabetes ratings? So here are numbers in Europe from 2021. So we are not, in this statistic, we are not the top one. We are somewhere around the top half of European countries. But also we are doing worse than our neighboring Nordic countries, Iceland, Denmark, Sweden, and Norway. So there is still work to do in this regard. Next slide, please. So I wanted to start by giving you a kind of historical point of view also. So we do have a very nice track record on being the front runner in prevention of chronic diseases. We have been doing very nice clinical trials. We started in the 17, not myself personally, but my colleague started in 17 with the North Karelia project and managed to reduce the number of people dying in cardiovascular diseases through population-based lifestyle intervention. One of the successful population-based trials. Then we continued by trying to tackle type 2 diabetes and also published our results as the first country in the world to show proof about the possibilities of preventing type 2 diabetes by lifestyle intervention. And after that, we moved on to dementia. And for that also, we do have the clinical proof that dementia can be prevented pretty much with the same kind of intervention. Next slide, please. And indeed, in the DPS study, we randomized people in the intensive intervention and control groups and followed them up first clinically and then via healthcare registers. And were able to show a remarkable reduction, halving of risk of type 2 diabetes And the good news also, like we saw in Mary's presentation, was that when people manage to learn their new lifestyle, then they are able to continue it, at least to some extent. On the right-hand side, we see the weight reduction results from that trial. So our intensive intervention participant achieved about 4.5 kilos weight reduction and gradual increase after we stopped the clinical intervention. Next slide, please. So I actually did my doctoral thesis based on the results of the DPS trial. So I had this nice picture in the front cover depicting, to my mind, how the top, the visible part of this iceberg is the actual diabetes. And then what is underneath the surface is the pathophysiology and all the underlying determinants that then lead to diabetes. Can you click on? So now during the rest of the 20 years of my career within prevention, I have reconsidered this graph. And now I think that the visible part is the prevention of diabetes in clinical setting, and the huge lump of ice is the large scale implementation of prevention. Next one, please. So when we got the results from the DPS, so our Finnish Diabetes Association immediately took these quite wonderful results and decided that now we need to implement this kind of intervention and rescue Finland from diabetes. So that's already about 20 years ago, 5 years project taking place in several areas in Finland, covering 1.5 million people living in these areas. And about 10,000 people with high or increased diabetes risk were identified, and almost 3,000 of them were taking part in the evaluation data collection. So based on that data, we could see that the mean weight reduction was about 1.2 kilos within these study participants, and 17% lost more than 5%. So clearly less than in the clinical trial. Also, the intervention was much less intensive. So the people participating in FIN-D2D had been number of counseling visits, about 3, mostly individual counseling by healthcare nurse. But in addition to these modest changes in clinical risk factors, there were also other outcomes, such as new ways of collaboration were built, multi-professional teamwork, and collaboration with other actors also. And during that project, we developed a tool for risk identification, the FIND risk, which is at the moment quite widely used in Finland and also many other countries. Maybe about 20 countries have made a translation for their own language. And finally, models of risk screening and lifestyle intervention were proven feasible in primary care. That was something that they were not used to do before that. My next slide, please. And then years passed, and maybe other problems emerged, and diabetes was not at the top of the list for some time. But then we did another go. We started the Stop Diabetes trial. It was an RCT within primary healthcare again, in 3 areas in Finland. And the general aim was to create a sustainable model for type 2 diabetes prevention in healthcare, rather like we heard about the Canadian project. So we wanted to use digital tools as much as possible for recruitment, intervention, and evaluation. But due to the short funding period, we only could have 1 year lifestyle intervention. We had 3 groups with standard care, which was the control group, and then group-based intervention and group-based and digital intervention. For these interventions, we had a very strong theory base for lifestyle change and utilize self-determination theory and habit-based approach. So during this 1 year recruitment, following by 1 year intervention, we identified 16,000 people at risk, mainly using this find risk score, which was implemented as an online screening tool. Less than 3,000 of these participants agreed to join the RCT. And after the 1 year, we saw modest improvement in diet and some reduction in waist circumference. But of course, 1 year is not enough to see anything in diabetes incidence. So we are planning to conduct a registered follow-up also. My next slide, please. So now we have conducted 2 large-scale implementation projects. So what has happened as regards to diabetes incidence and prevalence? So these graphs show type 2 diabetes in green and type 1 diabetes in blue. So you don't need to care about those curves here. And this data is based on registers, so it does not include people who are only or who are not aware of their disease, which we estimate to be about 20% at any given time. 20% of people with diabetes are undiagnosed. So we started with a DPS publication, continued then with the FIND2D activities, and the graph very nicely shows that the FIND2D was very, very well identifying people at risk, shown as the very steep increase in identified cases of diabetes. There were other things going on also, some changes in care guidelines also. But after that, we did see somewhat decreasing trend in incidence, and we were very hopefully waiting that is it now happening? But unfortunately then, during the COVID, we had a reduction and followed by increase, depicting probably that during COVID, people with diabetes were not diagnosed. So, but not really any effect showing that we are decreasing in diabetes. And on the right-hand side, we have the prevalence also showing that a steady increase. My next slide, please. So what might be the reason for these differences? So of course, in the clinical trials like DPS, the intervention is very much more intensive. And also in DPS, the participants were at high risk. They had to have IGT in impaired glucose tolerance test, and they also had to be obese and overweight at least. And for example, in Stop Dia, we had only 1 year intervention and very lower intensity of this counseling. and also the participants were lower risk at baseline. So what I would do differently if I had a chance and funding. So I would like to have an intensive phase of intervention followed by a maintenance phase so that people are not left altogether alone. I would focus on several lifestyle factors, but also take care that we can follow the costs of the intervention, clinical factors, diabetes incidence, and also incidence of other chronic conditions. I would do stratification according to risk so that people who need more support and are at higher risk would get more intensive intervention. And I would do collaborative implementation. So needs-based tailored intervention, provide training and tools, collaborate with local service providers, do proper follow-up and benchmarking, not only a few years project. Next slide, please. I will just quickly go through this. So we might have a perfect intervention, the thing on the right-hand side here. But of course, the implementation does not stand or fail only based on the quality of your how you deliver the intervention. So we need to understand the implementation as a collaborative process, not something that you just start implementing. We need to consider the policy measures, the external pressures, the systemic conditions, all of which can direct to us any direction, the good or the bad. We need to consider the healthcare culture, the resources, the knowledge there. We need to identify the target groups and consider also the equity issues, as we heard in the previous presentation, so that our intervention does not increase inequalities in health. And we have to focus on the big three, the capability, opportunity, and motivation, not only by the target groups or the individuals who are at risk, but also the service providers, because they are also individuals that need to change their behaviors. Next one, please. So I have a couple of examples of these different levels and domains of this implementation framework. So we have taken a small step forward in policy measures as the healthcare system is funded by the government in Finland. We have 21 healthcare services counties which get their funding from government, and 1% of this budget will be based on a promotion factor, which consists of 5 outcome and 8 process indicators. And one of these is implementation of lifestyle counseling for people at risk of type 2 diabetes. So it will be interesting to see next year when this is implemented, whether this has any effect on how the counties are organizing their work. Next one, please. Here is an example of external pressures that can act to the other direction, the unwanted direction. So people tend to think that they choose their own diet, but this is not correct. Here are examples from a grocery store manager who has posted in the social media some findings. For example, if you sell items in messy counter instead of nice piles, you increase your sales by 30%. Also, right-handed people tend to buy things that are on right-hand side. So by moving the dessert counter or the junk food counter to the right, he managed to increase the sale by 40%. So unfortunately, as a policymakers, we cannot do this somehow. So this is something really bugging me. Next one, please. Another pain is the medical devices regulation in the EU level, which is causing us to be very careful when we design our digital screenings and digital care pathways, as if these are defined as medical devices, which might take place according to this regulation, then also the cost and management of this becomes very, very complicated, and the cost becomes very high. So we hope that we find some sensible solution to this in EU level. Next one, please. And finally, I wanted to share very quickly a couple of ongoing activities that we are doing under the framework of Jagadi. You may have heard about the one of the largest EU activities, EU-funded activities in order to tackle cardiovascular diseases and diabetes burden in EU. There are 22 countries taking part, 76 participants implementing 142 pilot projects identified based on needs and gaps in individual countries. So what they thought that would be useful for them. And all these pilots follow the harmonized Jagadi implementation methodology with 15 steps and all the components on implementation science. Next one, please. That was my final one. So just examples of the 4 pilots that my team is currently leading. So we are trying to tackle the problems of awareness, people not being aware of their risks. So then providing low threshold lifestyle change support to people who would like to do something about their lifestyles, for example, by the people who have identified their risk, for which there has not been reliable support. Our third pilot relates to improving dietary counseling in healthcare by providing them a validated healthy diet index tool that gives an estimate of diet quality. And finally, we have a pilot focusing on immigrants who, based on other research, have more non-communicable diseases, risk factors, but less access to preventive services. And all these pilots we are conducting with our collaborators in the field. And for all of these, especially there is a focus on sustainability, not building a project, but making a sustainable change. My final slide is only to state what I already said. The implementation has proven to be challenging, but we do need policy measures, systematic approach to implementation, consideration of health inequalities, and change, in general, change in culture to see prevention as an investment rather than an expense. Thank you.
So thank you, Jaana, very much. That was a great overview of a sustained period of time and much activity in Finland and more broadly. So that's great food for thought, if I could say that. Could I have my slides back, please? And so our last of our 3 speakers, but certainly not least, is Dr. Jason Gill, who's a professor at the University of Glasgow. Jason, welcome to you, and thank you very much for being with us. Over to you.
Thank you. I'm delighted to be here. I'll just share my slides. Right. So, you seeing slideshow?
We're seeing the slide panel. Oh, there you go. All
We're
set.
good. We're good. Okay. Thank you. So I'm delighted to be here. I'm going to give a slightly different talk to the first 2, which are both fantastic. because I'm not going to give you any solutions. I'm going to give some reflections on ethnicity and prevention of type 2 diabetes. So I'm sure everyone in the audience is aware that prevalence of diabetes differs between ethnic groups. These are data from high-income countries, UK and US, showing the prevalence of type 2 diabetes in white Europeans, Black populations, and South Asians. So Black people have about twice the risk of diabetes compared to white people, and South Asians 3 to 4 times. One of the things that we also know is that prevalence of diabetes increases with BMI, but it's different between different ethnic groups. I'm gonna see if I can get a pointer up, pointer options. Okay, so if you are a white European woman, your diabetes risk follows this black line. And if we take BMI of 30 as the conventional point where we define obesity, and we look at the prevalence of diabetes, and then we move across to the other ethnic groups and say, which BMI gives an equivalent prevalence of diabetes, you find that in Black women, it's about a BMI of 26, in Chinese women, about 24, and in South Asian women, about 22. So a South Asian woman with a BMI of 22 has equivalent risk of diabetes to a white European woman with a BMI of 30. And these are the same data for men. Everything's shifted up. Men have higher risk of diabetes than women, but the pattern still holds. A South Asian man with a BMI of 22.6 has equivalent risk of diabetes as a white European man with BMI 30. And because of this, a number of bodies, including NICE in the UK and the World Health Organization, have said that we need to use different thresholds, ethnicity-specific thresholds, to define high risk. So what they say is a BMI of 23 in South Asians is broadly equivalent to 25 in Europeans, and 27.5 is broadly equivalent to 30. Those values are probably too high, as the data I showed you before suggest, but it's a move in the right direction. So the next question is, you've got this group, I'm mainly going to focus on South Asians here. You've got this group at higher risk of diabetes that you want to sort of prevent diabetes in. And you can use the interventions like the ones that Mary and Jaana talked about to try and reduce type 2 diabetes risk in South Asians. We did a meta-analysis led by Anne-Karen Jenham a few years ago, looking at how effective the lifestyle interventions were at preventing diabetes in South Asians. And we found that the current interventions worked. They reduced incidence of type 2 diabetes by about 35%. One thing that you notice from Norman's initial slide is if you look at a meta-analysis of all studies, it's about 47%. So the interventions seem to work, but they work a little bit less well in South Asians than other populations. And the other thing that was really interesting was there was actually a very, very small reduction in body weight, less than a kilogram. Interestingly, Raj Rapal and colleagues did a separate meta-analysis of weight loss interventions in South Asians, and they found exactly the same result. They have slightly different trials included, but on average, it was about a 0.25 BMI unit, which is about 3/4 of a kilogram in weight loss. So it seems to be interventions for weight loss seem to work less well in South Asians than other groups. This is data from interventions in South Asians with diabetes. So this is the standby study. So the standby study attempted to replicate the direct study in South Asians. So the direct study involved giving people with type 2 diabetes a total diet replacement where they had about 800 calories a day in meal replacements for 3 months, and then food reintroduction over a year. And what you found in direct is there was about 10% weight loss in average over a year. And in standby, with exactly the same intervention, we're finding a little bit less. And this is when people are provided with all the food that they're given. So it's unlikely to be adherence issues. So what we're finding is that lifestyle interventions that we use to prevent diabetes have a smaller effect on risk and on weight loss in South Asians compared to other ethnic groups. And weight loss in response to these interventions appears to be smaller. So a question is, does this represent a physiological difference in response to intervention? And if it does, the response would be, we need to do different, more intensive or earlier interventions. We might need to do a different type of intervention if the physiological response to intervention is different. So I'm going to share some data on potential physiological differences between ethnic groups. This builds on a review that Naveed Sattar and I wrote in the Lancet Diabetes and Endocrinology about a decade ago, looking at potential mechanisms via which risk of diabetes might be different in South Asians compared to ethnic groups. And one of the things that we found in a meta-analysis that we published in 2023 in Diabetologia, where we looked at all the studies published which looked at subcutaneous and visceral fat and the ones and liver fat in South Asians versus Europeans using MRI or CT scans. And what we found that was interesting was for an equivalent BMI, South Asian men have higher subcutaneous fat. The same amount of visceral fat, which is a surprise, it's different from the dogma, but more liver fat. And South Asian women have similar subcutaneous fat, similar visceral fat, and more liver fat. So it seems that South Asians put on fat in ectopic depots at lower BMIs. And this might be some of the reason why the risk of diabetes is greater at lower BMIs in these groups, and explains some of the earlier data that I showed you. One of the things that we wanted to explore was what happens when you take South Asians and you get them to gain weight in a longitudinal study. So we did the Glasgow study that we published last year in Nature Medicine. So this is the pinnacle of my career, coming up with the Glasgow acronym. So it's Glasgow visceral and ectopic fat with weight gain in South Asians. And what we did is we got some young South Asian and white European men. So they were aged about 22, BMI about 22. And then over 6 weeks, we fed them ice cream and Coca-Cola and pizza. And we got them to gain about 5 kilograms in body weight. And we looked at where the fat went in an MRI scan. We took an adipose tissue biopsy and looked at adipose tissue morphology. And we looked at metabolic responses to feeding meals, and we measured physical activity and fitness. And what we found is that we were successful in gaining weight. People gained about 1.4 units of BMI, exactly the same change in weight in the two groups. But what was really interesting is when you looked at the metabolic response to eating food, it was very different. So if you're a young, thin white European man, BMI 22, age 22, and you gain 5 kilograms, essentially nothing bad happens. Your insulin response to eating a meal stays pretty much the same. But if you're South Asian, that same weight change causes about a 40% increase in your insulin response and an insulin resistance. And there was a hugely significant interaction with those terms. What we also found is when we looked at how people gained weight, we found that both groups gained adipose tissue, but the Europeans gained a substantial amount of lean tissue as well. So when they had positive energy balance, they put on lean tissue as well, which the South Asians didn't. And this might, in some ways, explain the different metabolic response, because lean tissue provides a buffer to the adverse effect of weight gain, because you've got increased lean tissue to put the sugar into. The other key thing that we found was that the distribution of size of adipocytes was very different. So you've got white Europeans adipocyte distribution in blue and South Asians in red. And what you see is the South Asians have much bigger adipocytes. So much greater subcutaneous adipocytes, much larger adipocytes. And one thing we found that with weight gain is that the white Europeans, what happened was the number of very small adipocytes dropped. So basically they were able to recruit the small adipocytes and make them bigger, whereas that didn't happen in the South Asians at all. And this actually predicted to some extent the adverse metabolic response. So we had two key things that predicted the adverse metabolic response. One was the proportion of large adipocytes at baseline. And if you look at the R squared here, it explains about half the variance of the change in insulin sensitivity. And the other was the change in the small adipocytes with weight gain. But it's not just adipocytes that look different between South Asians and white Europeans. There's differences in fitness related markers as well. We've shown that on average, South Asians are about 20% less fit, cardiorespiratory fitness, than white Europeans. And if you statistically try and calculate how much this explains insulin resistance, it explains about 2/3 of the difference in insulin resistance between the ethnic groups. We've also done work to show that South Asians on average muscles burn less fat. And this again is associated with insulin sensitivity, both at whole body level. And if you take a muscle biopsy and look at insulin signaling, it's also associated there. And that South Asians on average have less strong muscles. And this again, we've shown is associated with increased diabetes risk. So there appears to be some innate ethnic differences in biology related to adiposity, fitness, and strength, which might contribute to differences in insulin resistance and diabetes risk. So a question is, with interventions, should we be taking this into account and do slightly different interventions to take into account these underlying differences that we see in biology which influences risk? But there's another part as well, because the differences in interventions and the effectiveness of interventions might reflect differences in engagement and adherence to interventions. So it might be that the interventions are not culturally appropriate. And if that's the case, we need to adapt the intervention to improve engagement, adherence, and motivation, the things that Jaana and Mary were talking about earlier. So it's really important for us to understand the relative contribution of these two, because the solutions that we put in place will depend on which of these is the case. So there is some evidence that engagement and adherence to interventions is different as well. So if we look at the implementation study in England, the National Diabetes Prevention Programme, which is based largely on the Finnish DPS that Jaana presented earlier, what we find is there's greater dropout in Asian and mixed groups. And we find that weight loss and HbA1c reduction is lower in non-white groups than white groups. So the intervention seems to work less well in South Asian groups and in all non-white ethnic groups. And this might be due to differences in engagement. I thought I'd just share this study from Nikhil Tandon. It's a really well done study published a few years ago. This was in, I think it's Bangladesh and India. And what they did is they took about 1,600 women who had gestational diabetes. So that we know that if people have had gestational diabetes, their risk of progressing to type 2 diabetes is really high. So they thought this was an ideal population to do the type of diabetes prevention interventions that have been done in other populations. They people have had gestational diabetes and give them these interventions. And essentially what they found is it didn't work. So there was no change in glycemic progression. But if you look at the small print, they also didn't change physical activity, they didn't change sedentary behavior, and they didn't change energy intake. So the intervention didn't work, but it worked because they didn't change the behaviors that need to change. Which leads us to, we need to tackle this problem of poor engagement and adherence to lifestyle interventions, which might contribute to the limited effectiveness. And some questions are, so how do we do this better? One of the things that we have been thinking about in Glasgow is the need to develop a culture, we call it a culturally relevant or a culturally appropriate hook to get people to engage. And one study that we did this in was a very different study focused on men. And we focused on the fact that a lot of men have a very strong allegiance to their professional football club, professional soccer club that they support. So we did a study across 15 clubs throughout Europe. So clubs you heard of: Manchester City, Arsenal, Benfica, Porto, PSV Eindhoven, clubs like that. And what we did is we got the clubs to recruit their male fans, and the intervention was actually delivered by club coaches. So we trained the club coaches to deliver the intervention, and it worked really well. We did a study in 1,100 men over 1 year. They lost weight, they increased physical activity, and they improved a whole bunch of biomarkers, including insulin sensitivity and inflammation and things like that. So it seemed to work really well. But what we did is we went to where people were and delivered the intervention. We've done a little bit of work to see whether we can do this in South Asian populations. And we've done some feasibility work on Bollywood dancing in South Asian women, which is a culturally appropriate intervention. And it seems to be acceptable. We've got data at 3 months, and it seemed to work at 3 months. I guess the caveat is everything works at 3 months, and we don't know whether things will work longer term. But I think we need to explore how we might need to segment the population and do interventions which are specifically relevant to particular groups of people to help in the future. I'm gonna finish off just here and summarize that in high-income countries, we think that the influence of obesity and physical inactivity differs by ethnic background, and there's physiological factors here. We know that current physical activity and diet interventions for weight loss to improve glycemic outcomes are less effective in non-white groups. And I think the key thing is we need to understand the extent to which this is due to ethnic differences in intervention effectiveness because of physiological response differences, and also differences in engagement. And if we can kind of disentangle those two, and I think we need to do trials to do that, we can develop better interventions for the ethnically diverse populations that we have in many parts of the world. So I'm just going to finish off there. So thank you very much.
Jason, thanks so much. Fabulous talk. So now we've had 3 really great talks and focusing in overlapping but distinct ways. And I would just remind our attendees that you can enter your comments and questions using the question and answer app, which is part of this platform. So please do so. I already see one question. But before we get to that question, I'm going to ask Juliana if you can put the faces of the images of our 3 speakers to be visible to everyone, and then just have a short round of, so what did you think of what the other person said? What really hit you? So perhaps we can do that. We can see everybody, and then we'll proceed in that direction. Right, yeah, this is great. We just need, there's Mary, so welcome back, Juliana, Jaana, and Mary, thank you. So perhaps I can ask Mary, given what you heard from your colleagues, is there anything in particular that sort of struck you?
Definitely. I was nodding my head the whole time, Jaana and Jason. It's, it seems as though the same challenges that we face at population level are consistent across the regions that we work and do research in. And I think what is really interesting is that there's the opportunities for long-term assessment or implementation barriers that you were suggesting, of really understanding moderations or moderators to engagement and adherence. Jason, these are issues that we all face, and they're costly to assess and to intervene with. And I think that's where there's possibility for perhaps greater sharing of ideas, of resources, and actually of data across countries to try and address and really decipher, where we can move forward. Just because they're the same challenges, right? Yeah. Implementation, effectiveness, culturally relevant interventions, etc.
Great. Thanks, Mary. Jaana, your thoughts? Quick thoughts?
Okay, so first of all, from Mary, I really loved the way you were able to present the quite complex interventions in such a clear way. So, and maybe I was a little bit jealous of your funding also. Because it seems that you have some authority that understands that it's not enough to do a clinical trial and have the publication, which seems to be a problem in our country, that the short-term fundings and minimum fundings, and you really can't then have any effective interventions and long-term results. And for Jason, in your presentation made me miss clinical research. So really, really interesting what you presented, and especially as we are also one of these pilots at the end of my presentation is with Somali people who also have same kind of issues, and we are presently conducting a culturally adjusted intervention provided by peer educators, because this is one finding that we have seen, that you have to be from the same culture to be able to counsel the others. And now we have ongoing trials going on in that regard. So I will definitely look up your publications.
Great. Thank you, Jaana. And Jason, any additional comments from your side?
Thank you. I'll maybe just touch on one thing Jaana said at the end. So we're doing some work in Malawi on diabetes. And it's really fascinating because people get diabetes at very low BMIs, and BMI doesn't seem to predict diabetes risk. And everybody is doing 10 times the physical activity recommendations, or several times. So everyone's super active and people are lean and people are still getting diabetes. And our preliminary work suggests it might be different things. So we're showing that low protein intake and inflammation seem to be stronger signals for diabetes risk in that population. So it might well be that in certain populations, particularly if you move out of high-income countries, it's not just transporting the interventions that we know work and trying to make them culturally appropriate. We might need to do completely different things. And I think understanding whether in Malawi, whether we need to give people more protein, or it might be inoculating people against malaria stops the inflammation, which then stops diabetes. You know what I mean? It might just be different things that we need to do, and we just don't know the answers to that. So I think that's fascinating, and the Somalian stuff I think would be really, really interesting. The thing that I took was I am so pleased that this work on implementation is being done, and just seeing how hard it is to actually do things long term, because you've got so many moving parts in this complex system. And I was often frustrated that we stopped at the end of the trial and saying this stuff's great, someone should go and implement it. So I'm really fascinated and really pleased this work is being done in such an effective way.
Great, thank you. So we have some comments and questions from our attendees, and which is great. I'm going to provide these. So Mary, first, let's define YMCA, because I think that was on your slide. And the overall question, this is really my question, it's to riff off of John's question. It's, well, in a sense, so part one is government sponsored through the public health system intervention versus a more nonprofit or private location for these interventions. And because the YMCA is not a government funded operation in Canada, as I understand it, yet it's working in partnership with you, I think, with respect to what you're doing. So one question for us all, I think, is what's the location of this intervention? Is it best to be within the public health system where you struggle with primary care and funding and time and all the services that have to be provided, or you do it differently? And do we have any evidence of what the location should be and its relative effect? So just some quick thoughts on that, because now the questions are really coming in. Just Mary, what's your thought on that? Why did you choose what you did?
Okay. So quickly, YMCA is formally known as the Young Men's Christian Association, which has religious connotations and history. So worldwide, that is no longer, it has moved itself from that, but that's what it originally stands for. And then there is also Young Women's Christian Association, or YWCA. So briefly, the reason why I chose to partner very early on is because one, it's worldwide. So there's the opportunity. I was always thinking, implementation broad scale. It's a charitable organization with registered status. And one of the things that is very important to me is to partner with people who have the same values. And one of the values is to ensure accessibility to those who need it most. So within YMCA's in Canada associations, there is an opportunity for a sliding scale membership, meaning that if income is absent, opportunity for absolutely free programming is available. And that works really well with my values and my interest in serving those who experience the most barriers to accessing programming. So in terms of answering the question, Norm, in terms of where do we best, partner, where do we best deliver?
Yeah.
I think we need to best deliver where people are most comfortable and ready to be present at. And similar to Jason's Soccer Fit program, which has been, replicated in Canada with ice hockey groups as well. This is where individuals who are most in need of the program are willing to go. And we must think about cost sustainability, right? And so if we're going to utilize, hospital or health services areas, I'm not sure if that's, it's got long-term sustainability written there. So I think if these are reputable locations where people are willing to go, then that's great. And that also addresses maybe some of the questions in the chat discussing upstream, downstream. In reality, of course, we need to meet people in the middle. We need to focus on individual behavior change at the population health level. We need to be looking at systems level approaches, which include where we deliver programs, who's trained, how we train those people at broader than just, one by one. But we certainly can't forget about evidence-based individual behavior change.
So let's just push the ladder a little bit as per John's question, because obviously a lot of these interventions are individual based. They may be community based, but they're individuals. But we have an overall structural environment that we're working in terms of the food environment, in terms of the role of physical activity in our societies. These are higher levels of organization, policy, and so on. And some societies have been pretty reticent about really getting at these underlying factors. And so the question is, are we punching in the right direction? So who'd like to take that one?
I'll maybe add a reflection. So
please.
One of my favorite phrases is both and. So I think we need to do both. I think we need to hit this from as many angles as possible. Sometimes people criticize the individual level approach because they say that it means that the population level approach is not prioritized. And it's an excuse for saying it's all down to the individual behaviors. But if we just focus on the population, there's going to be people within the population who need more help than just reducing the amount of sugar in drinks. There's going to be so I think we need to do both together. So we have this overall approach to sort of change the whole system, and then there's going to be something targeted on the people that need who need the extra support as well. But it's really hard to do that. But I think that's my idealistic answer, I guess.
Yeah, it's very good. Yeah, very good. So,
I would like to echo Jason's response. Very good. We need both. And having an effect on the, for example, food environment via taxation or pricing or availability or something that has proven to be so politically difficult. Yeah. And like I showed the example, so everything we would do for good purpose, that is very strictly regulated. But then the shop owners down can do anything then and laugh when they go to the bank.
Well, speaking of the bank, do we have a persuasive business case to present to policymakers about the cost effectiveness of the widespread investigations and interventions that would be needed, and how in the end it will or will not be economically beneficial? Because they're often very concerned about that. So, Mary, you're shaking your head saying,
absolutely.
Great question, but we don't have the business case, or
we're working on it.
So,
certainly measuring health care resource utilization as people across, at least in Canada and Australia, are going through our program. And what we, loosely, we know that individuals living with prediabetes are typically using less healthcare than individuals who have progressed on type 2 diabetes. They're also typically 10 years older. They're typically have less comorbidities, etc. But there still is some usage. So give us a few years to fully and robustly collect that data.
Yeah.
And there is some data certainly available that has been assessing DPPs and the healthcare savings, and that at least in Canada is at the provincial level. And what we really need to do is go back to the bank or and work with our health economists and do that federally or across multiple countries to just repeatedly demonstrate that it's such a cost savings.
Yeah.
And then just to chime in there with somebody's great question about, where are we targeting in terms of lifestyle or medications, et cetera.
Yeah.
Of course, we need both, right? And as Jason was alluding to, and I think one of the real beauties is when we do real world interventions, we must understand how does this intervention work as an aid, as a benefit to, for example, continue to improve cardiorespiratory fitness. Sorry, my dog is now up.
Yes,
and prevent muscle wasting, etc. There's benefits to all these approaches of doing it together.
Yeah. Well, that's good. I'm glad you addressed that. And Mary, I'd ask you in the question and answer, you'll see Ruth has asked you a very specific question about your questionnaire, so maybe you can respond in text to that. Meanwhile, let's go to Eileen's question, which recognizes, as we've been discussing, that government funding can be, quotes, short-lived, meaning very sort of study-focused, but not necessarily long-lasting. And so what's the persuasive argument to the policy side to say invest for longer and in different shapes and sizes, RCTs to intervention trials to spread and scale, et cetera? How do we present that case? I think people are worried about the short-lived nature of investment and therefore not learning enough for long enough. So that's one question. I see you sort of brooding on that. And the other question is also riffing off Eileen's question is, we live in a world of omics. And of course, Jason, you've already said a lot about interrogation of metabolic profiles, but do we have more to go?
Yeah, so I wonder, so I think both those two questions could be related.
Yeah.
So one of the challenges with committing to the long-term funding that's needed is the people who are in power are probably not going to be in power when the results are. They're going to spend money, but they're not going to see the benefit. So you kind of have this problem in a democracy where it's hard long-term. I do wonder whether looking at some of the omic changes, which some of them have been shown to be early markers of future disease risk in a more comprehensive way than the markers that we normally measure, might be a way of showing earlier benefit of some of the upstream factors. In a trial, you can show someone's HbA1c changes or whatever quite easily. But at the population level, it's quite hard to measure these things. So it might be you do these interventions which might take 10 years to decide to have an effect on diabetes or heart disease risk or whatever it is. But it might be that with more sophisticated biomarkers which change earlier using some of these omics, you might be able to say, well, these changes are quite predictive of a future, and that's happening in drug trials to some extent now, where drug companies will look at these things rather than doing a big trial, and you've got these signals that you can see a change in 3 months, which will predict cardiovascular outcomes in 3 years pretty well. So we might be able to use some of those technologies in our public healthy type interventions to get an idea of the things which have the biggest effects. I think there's scope to do things a little bit differently. Might involve thinking out of the box a little bit.
So in the remaining minute or so that we have before we conclude, and I thank you again, I think one of the questions, final questions, relates about riffing off the patient-oriented research movement, is co-creation. That is, designing interventions from the beginning with the communities so affected. And of course, this relates heavily to what you've been talking about, because you're saying people are different, people are diverse, they have different risks, they have different cultures, experiences, and so on. So where are we at with that? Are we one size fits all? I doubt it, but are we really explicitly engaging and co-creating? Mary, what are your thoughts on that?
Yeah, I'll start. Absolutely, resoundingly yes, both with decision makers, policymakers, but also in the following question, multi-section. So business, industry, for-profit, not-for-profit. Absolutely, that's our future, and to support Jaana's desire for long-term funding. That I believe that's really where we need to move. Exactly. And when developing my diabetes prevention next interventions, there is definitely co-creation involved, from the name of what we're calling it to what our outcomes are, to where they want us to intervene, like which communities, etc. And so I think it's hinted in the questions there, and I couldn't agree more. It's where we need to go.
Any additional comments on that particular question, co-creation?
I've got a small comment. So I mean, I've involved a bit of co-creation, and one of the challenges you find is if like co-creation leads to like locally relevant solutions.
Yeah.
And you kind of have something which is for this particular population, something for a different population, something for a different population. So it's hard to scale if you kind of have to co-create everything. And what you find often is 70% of it's the same, right? And there's bits around the edges. And I find that when we go into co-creation, we often start from a blank piece of paper as if we know nothing.
Yeah.
And I wonder whether we can tweak the process a little bit. These are the things that we know. These are the things that might be relevant to this context, rather than sort of reinventing the wheel over and over again. I don't know. I don't do this very much. It'd be interesting to speak to Mary and Jaana, who do this a lot more.
Okay.
Yeah. So
Jaana?
we are not doing that enough yet. We are heading to that direction. And even though after the co-creation process, the intervention is more or less the same as we planned in the beginning, that creates the engagement and ownership within the community, which is also really, really important.
Yeah, I think that's a great comment. That's a great comment to conclude with, actually. Two notes of appreciation. One is I want to thank our three speakers. I think you've all been terrific, raised such great issues, presented so beautifully, and great conversation among yourselves and in response to the questions and comments from our audience. So thank you very much. And my thanks to HDHL. I mentioned at the beginning that CIHR is a proud partner of HDHL. It's a personal pleasure for me to interact with my colleagues, principally in Europe, in this really important endeavor, and to have moderated this session with you today. And so with that, I thank you all again. I wish you all a good day, and I think that this will be available for viewing from people who weren't able to make it today. So your conversation will live on into history. So thank you very much. All the best.
Thank you. Bye-bye.
Bye-bye.